Welcome guys, in this second set. After completion of the first 10 MCQ, we are moving to the next 10 set of the question. So here they are asking about a 17-year-old male who is hypertensive. So young age hypertension presented with buffalo hump and abdominal stria, subjected to high dose dexamethasone, even after which ACTH level remain elevated, most likely diagnosis. Okay, so this is nothing but a Cushing syndrome. And Cushing syndrome is a umbrella term, guys. Now it is a constellation of symptom of glucocorticoid excess of any origin. Now if it is due to pituitary edema, this Cushing syndrome is known as Cushing disease. So how to approach when you suspect a case to be a Cushing syndrome? So once we suspect a case to be Cushing syndrome, mainly based on symptoms, that is of the central fat, myopathy, which is usually proximal in nature, stria, hirsutism, hypertension in young, as the question is suggestive. Usually the hypertension is secondary and diastolic is raised in mostly in case of Cushing syndrome. So if such symptoms are present in somebody and we suspect the Cushing, then only we go for further evaluation. So first step in such suspicion is screening or establishing the diagnostic of Cushing syndrome. Alright, and to rule out exogenous steroid intake. So how it is done? It is done usually in 3 steps, either checking in the urine, that is 24-hour urine cortisol. Alright, checking for the midnight serum cortisol level, or after low dose dexamethasone suppression test. So what is most commonly employed? Most commonly employed for the diagnosis of this or screening of Cushing syndrome is low dose dexamethasone suppression test. What is done here? Here 4 tablet of 0.5 milligram dexamethasone is given as QID dose for 2 days. Alright, following which serum cortisol level is checked, and if plasma cortisol level is more than 50 millimole, if plasma cortisol is more than 50 millimole, it is considered to be positive for the screening test. Once it is positive, you have established that it is a Cushing syndrome, then we go for the steps 2 to find whether this Cushing syndrome. Then we go for step 2 to identify whether this Cushing syndrome is due to ACTH excess, that is ACTH dependent Cushing, or it is something that steroid body is getting synthesized in body apart from the dependency on ACTH, that is ACTH independent. So how to establish this diagnosis of ACTH dependent and ACTH independent? Just check the plasma ACTH level. If it is more than normal or high, it is ACTH dependent Cushing. So we check for plasma ACTH. If it is more than normal or high, it is ACTH dependent, and if it is low, it is ACTH independent. If it is suppressed, then it is something to do without the source of ACTH. So most likely these ACTH independent sources are usually macro or micronodular hyperplasia of the adrenal gland. So or unilateral adrenal mass is associated with ACTH independent Cushing syndrome. So adenoma of adrenal gland. Alright, and when it is ACTH dependent ones, either it is pituitary tumor which is releasing ACTH and acting on adrenal gland to release cortisol, or there is ectopic source of ACTH, usually small cell carcinoma lung. Ectopic ACTH source. Alright, which is again raising cortisol. So how to approach differentiate between pituitary tumor and ectopic ACTH source? To differentiate between these two, next step involves is subjecting the patient to high dose dexamethasone. High dose dexamethasone means 2 milligram QID for 2 days. Alright. After that, serum cortisol level is assessed. Serum cortisol level is assessed, and if it is more than 50% suppressed, what does it mean? It means that HPA axis is getting suppressed. So HPA axis is getting suppressed. Therefore, source of this ACTH is pituitary adenoma, or other words, source of Cushing syndrome is Cushing's disease. And if still after giving high dose dexamethasone cortisol level is not suppressed due to suppressed, that means HPA axis has nothing to do with the ACTH level which was high in our body, in the patient's body. That means there is some sort of ectopic source. Okay, there is some source of ectopic ACTH production source. Now coming back to the question, if you just again see what was they are asking about, they are asking about the patient was subjected to high dose dexamethasone. So if patient was subjected to high dose dexamethasone, that means we already know it is something to do with ACTH dependent ones. And if it is ACTH dependent, we after giving high dose dexamethasone, ACTH level remain elevated. So the source of ACTH is not the pituitary but something other than that, that is ectopic ACTH. So answer here is ectopic ACTH. Alright, you can see the same thing here in this Harrison chart. So what is the first step? First step is to check whether you have clinical suspicion of Cushing or not based on central obesity, proximal myopathy, stria, diastolic hypertension, osteoporosis or hirsutism. Once you have clinical suspicion, next step involves screening and confirmation of the diagnosis either through 24-hour urinary free cortisol, dexamethasone overnight test, midnight salivary cortisol, or low dose dexamethasone. Now once it is positive and you know that this is a case of Cushing, next step involved is check for the ACTH level to differentiating between ACTH dependent or ACTH independent. ACTH independent is either bilateral adrenal mass or unilateral adrenal mass, and ACTH dependent you need to check for high dose dexamethasone suppression, and if it is suppressed, that is pituitary edema, Cushing disease, or if it is not suppressed, it is ectopic ACTH production. Okay, all right. So coming to the next question, it is about a clinical examination. It says which part of nervous system is affected when Hill-Shin test is abnormal. All right. So Hill-Shin test is nothing but a cerebellar function test. Cerebellum in our body is basically responsible for equilibrium, guys. Coordination, equilibrium, and the smoothness of movement is maintained by cerebellum. Now, specific tests to evaluate cerebellar function, if we check in upper limb, are finger test, then finger nose test, dysdiakinesia, and macrographia. Whereas in lower limb, the test to check for cerebellar function is Hill-Shin test, where coordinate movement of one foot is to keep from the shin to heel. Patient need to keep it and make it a repeated movement. And another one is fast stepping test, tapping the foot in floor very quickly, similar to this is dysdiagonal equivalent, repeated movement with feet, and as well as the pendular knee jerk. Therefore, answer here is cerebellum. All right. Okay. So coming to the next question, it says a 30-year-old Kerala farmer presented with acute onset fever, headache, dizziness after consumption of dry fruit and death. So what is the most likely diagnosis? So fever, headache, dizziness, this constellation of symptom along with risk factor of presence with close contact, that is the fruit fly or the contaminated food, and it's nothing but a case of Nipah virus disease. Okay. So comparing other options, now what are the features of Ebola virus? Ebola virus is similar to the hemorrhagic fever. So Ebola hemorrhagic fever presentation is almost similar to that, but along with there is very high grade fever, and often transmitted, airborne, associated with rashes and decrease in the blood counts due to the hemorrhage. COVID-19 will have respiratory syndrome predominant. Zika virus is arthropod borne disease. So it is similar to dengue but with minor symptom. Often arthralgia, joint pain and fever is present and need to manage only with paracetamol. So answer in this question is Nipah virus. So all of the following are seen in Cone syndrome except. So okay. So what is Cone syndrome, guys? Cone syndrome is a case of primary hyperaldosteronism due to unilateral adrenal mass. Okay. So let's just explain the topic together. So if you see primary hyperaldosteronism, that is increase in the aldosterone level in the body. All right. So what is the effect of aldosterone in the body? First of all, where is the aldosterone getting secreted from? It is secreted from adrenal medulla, from the zona glomerulosa. If you check this to be medulla. So from the zona glomerulosa, aldosterone is getting secreted. And what is its effect on the body? It affects mainly in the cortical collecting duct, in the principal cell, P cell of the cortical collecting duct, and P cell of cortical collecting duct, and result in secretion of intermediate peptides, aldosterone intermediate peptides, which acts on epithelial sodium channel to mediate its action. So what does epithelial sodium channel mediate its action? It causes sodium and water to get reabsorbed and it throws away potassium and H plus against it. Okay. So what is the manifestation? Manifestation will be as sodium and water is getting reabsorbed, patient will have hypertension, number one. As potassium is thrown out of the body, it will lead to hypokalemia, and along with it H plus ion has also been thrown out, so there will be loss of the acid in the body resulting into alkalosis. Okay. So this is the metabolic derangement seen in case of Cone syndrome or primary hyperaldosteronism due to unilateral adrenal mass. So coming to this question once again, it says all of the following are seen in Cone syndrome except. So hypertension is seen, metabolic alkalosis is seen, no acidosis is not seen. Palpitation sometimes can be seen associated with the hypertension in such patients. Okay, palpitation is again due to the aldosterone excess. Now coming to the next question, in a 45-year-old male, on clinical examination and measurement of vitals, you notice during inspiration, systolic blood pressure decreases of 15 mm of mercury. It is seen in all except. Okay. So what is basically they are explaining in this question? They are explaining the pulsus paradoxus. So what is pulsus paradoxus, guys? Pulsus paradoxus is nothing but a physiological exaggeration of physiological phenomena. So what happens in inspiration is, we have got four chambers in heart, right? We have got four chambers: right atrium, right ventricle, left atrium, and left ventricle. RA, RB, LA, LV. So during inspiration, intrathoracic pressure decreases, resulting into increase in venous return. So venous return to right atrium increases, more flow to the right ventricle, and right ventricle get distended. Once right ventricle get distended, it makes the left ventricle to collapse in size. So during inspiration, cardiac output will also decrease as left ventricular effective volume is getting decreased. Alright. So cardiac output, it decreases. This decrease in cardiac output, what will happen? Due to the decrease in cardiac output, systolic blood pressure decreases. Alright. Systolic blood pressure decreases, and this is a normal phenomena. Now, in some condition, there is over-exertion of this physiological phenomena. Suppose in condition when there is pre-existing causes, like mainly for cardiac tamponade, there is tamponade effect from outside. That's why during inspiration there is more pool of the blood and increase in venous return. Right ventricular free wall pushes the left ventricular much more and decreasing in much more in systolic blood pressure. So in cardiac tamponade, this normal phenomena is exaggerated, and when then it is known as pulsus paradoxus. Similarly, it can be seen in other conditions like massive PE, or severe obstructive lung disease when there is already low intrathoracic pressure, severe obstructive lung disease, or bronchial asthma. Okay, so what happens in HOCM, guys? In HOCM there is an entity which is seen, which is known as reverse pulsus paradoxus. So what happens here? There in HOCM, with inspiration, systolic pressure increases. Why increases? Because there is dynamic outflow tract obstruction due to subaortic stenosis. In case of HOCM, there is dynamic outflow tract obstruction resulting into increase in systolic blood pressure in case of inspiration. Therefore, it is associated with reverse pulsus paradoxus. Okay, so answer here is HOCM. Beside HOCM, reverse pulsus paradoxus can also be seen in LV systolic dysfunction if we are giving positive pressure ventilation. Okay, so LV systolic dysfunction with positive pressure ventilation, HOCM with dynamic outflow tract obstruction, or isorhythmic ventricular rhythm. These are the cases in which we can see reverse pulsus paradoxus. So in the next question, it was saying about a 15-year-old child who presented with pallor and fatigue. MCB was low, hemoglobin was low, iron profile suggestive of reduced transferrin, increased TIBC, and most likely diagnosis. So this is a very straightforward table-based answer. So here we have pallor and fatigue and MCB low. So what are the differential of low MCB? We know differential of low MCB are iron deficiency anemia, thalassemia, sideroblastic anemia, and anemia of chronic disease. All right. Okay. So what are the change in parameters in all of these, guys? Let's check. Iron, TIBC, percentage saturation of iron, and ferritin. Ferritin is the storage form. Okay. So what happens in iron deficiency anemia? In iron deficiency anemia, storage form declines, iron also gets declined, but binding capacity of the transference is very high to the iron. The to TIBC is increased, iron is low, ferritin is low, percentage saturation is also low in iron deficiency anemia. Contrary, in anemia of chronic disease, iron will be low, TIBC will be low, binding capacity decreases, but ferritin, there is enough storage in the body. Ferritin storage is enough in our body, and percentage saturation is also low. Alright. Now comparing thalassemia and sideroblastic anemia, in both of the cases iron will be normal or high. Binding will also be normal in both of the cases. Percentage saturation and ferritin storage will be more in case of thalassemia as well as in case of sideroblastic anemia. Alright. So if you see the question here, it is what is saying. It is saying MCB was low, hemoglobin is low, iron profile suggestive of reduced transferrin. So transferrin is low here, and increased TIBC. So increased TIBC, reduced transferrin saturation. So this is suggestive of iron deficiency anemia. All right. Okay. Now coming to next question, it says again another question from anemia. A lactating mother who follows strict vegetarian diet presents with fatigue, weakness, and numbness in her extremities. Which of the following deficiency is most likely present in her case? So strict vegan diet is the key, guys. So what will be seen in vegan diet? Megaloblastic anemia are usually seen, and megaloblastic anemia can be due to two reasons: either due to iron, vitamin B12 or folate deficiency. Now how to differentiate between the two? Neurological manifestation will be seen in vitamin B12 deficiency but not in folate deficiency. As neurological manifestation like weakness and numbness is present, obviously this is a case of a vitamin B12 deficiency. Now coming to next question, it says iron absorption is decreased by which of the following? So in iron deficiency anemia, so what is the iron absorption form? We need to understand. So there are iron is available in ferric form and ferrous form. Iron is absorbed in the body in the form of Fe2 plus form, right? So vitamin C promotes this conversion of Fe3 to Fe2 plus. Therefore, vitamin C rich diet promotes absorption of iron in the body. Vitamin C rich diet promotes absorption of iron. So therefore, amla and lemon, which is vitamin C rich, will promote the absorption of iron. Whereas sprouts itself contains high source of iron. All right. Tea contains phytins. Phytins prevents iron absorption. Okay. So coming to next question, a 55-year-old female newly detected type 2 diabetes presented in OPD for 3-month regular follow-up. Target HbA1c. Target HbA1c, remember guys, in treatment of new detected diabetes is 7. So among this option, 7.5 is higher, 5 and 8 is 5 is very low, and 8 is higher, obviously. So in such cases, target will be around 6.5. 6.5 is obviously the baseline target cutoff for HbA1c for diagnosis of diabetes. So next question is amiodarone causes all except. So amiodarone is a broad spectrum antiarrhythmic drug, and it is one of the favorite for the examiner. So remember, don't get confused by these two options, hypothyroidism and hyperthyroidism. Both can be done by amiodarone. Amiodarone has high value of iodine in it. As high value of iodine, it promotes iodine gets incorporated in the thyroid hormone synthesis steps and results into Wolff-Chaikoff effect, which causes hypothyroidism, and due to George-Bastos effect, there is thyroiditis resulting into release of thyroid hormone into the body and causing hyperthyroidism. So hypo and hyper both can be present. Pulmonary fibrosis is known complication. Gynecomastia is not seen in amiodarone. So what are the drugs which causes gynecomastia? Gynecomastia is caused by the disorder D for digoxin, I for isoniazid, S for spironolactone, K for ketoconazole, and O for estrogen. So these are the medication which causes gynecomastia.